Hello and welcome to Pulmonology Read Aloud. Today I'll be reading aloud another sleep related article which was recently published in the year 2025. This article is a guideline statement on obstructive sleep apnea evaluation management in adults who have been hospitalized for any other medical care. Now, this document, although a very short document with only four recommendations, is an important tool for us to kind of increase the screening of patients suspected to have obstructive sleep apnea. It will also help us understand and give more credence to interdepartmental references for sleep apnea screening so that more and more patients who require diagnosis can be helped. So let's read this short document, which gives us a brief on what to do if a patient is admitted for another issue and sleep apnea is suspected. Before I start reading this guideline statement, it's important to know that here again, based on a systematic review of the literature and the evidence, a grading of recommendations has been given, with the strong recommendation meaning the one which we should follow under most circumstances, and conditional meaning the one that requires our clinical knowledge and experience considering the patient factors. Most of these statements that are mentioned here are conditional recommendations. So, this guideline focuses on this area where we know that whenever patients are managed as an inpatient care, there is a diverse role of various factors involved. And here we've seen that association of sleep disordered breathing has been noticed with almost a 17% increased length of stay and 67% increased costs for patients. So, this guideline looks at this population where almost 25 to 77% of patients hospitalized may be having sleep disordered breathing. And to prevent this increased length of complications and stay because of untreated sleep disordered breathing, they are targeting this population to find out what is the prevalence and to help guide treatment. The tools that have been suggested in this guideline for screening patients include validated questionnaires like the Stop Bank questionnaire, which is easily available, or an overnight high resolution pulse oximetry. Now, when we talk about overnight high resolution pulse oximetry, it basically means that in the patient's bedside, we are trying to do continuous saturation monitoring with pulse rate monitoring and also looking at the frequency and pattern of the desaturations. So, this overnight variability in oxygen levels can guide us as a screening tool by capturing data using a device with shorter sampling intervals so that you can detect a cyclical desaturation pattern and you would know that this patient may be having obstructive sleep apnea. So how it is performed essentially is that you use your finger probe as a pulse oximeter sensor before sleep, and then overnight a continuous recording occurs, and the next morning, we look at the oxygen desaturation index, we look at the repetitive dips in the oxygen level, we look at the pulse rate variability. And in a hospital setting, a high risk patient can be identified, and it can also assist decision regarding PAP therapy. So, the timing of this screening is usually when the patient is medically stabilized. So, if your patient is in an ICU, you would not want to do it. If he has an oxygen requirement because of his medical condition, you may not want to do it. Once he's stabilized, possibly due for discharge, and you have a high suspicion, you can quickly deploy this in wards and with minimal patient discomfort in the high risk population. So, patients with heart failure or stroke or obesity or who came with atrial fibrillation or patients you know are of COPD, you can do it. But remember that the limitation is that when you're using HRPO or high resolution pulse oximetry, you're not diagnosing definitive OSA because you do not know whether these events were obstructive or central. You're not checking the airflow, the sleep stages. You may miss RARAs. So, all of this is affected. Hence, a formal sleep testing will be done later on, but it is a good triage tool or a screening tool according to the guidelines. In this regard, they have quoted two key papers by Sharma and group, one which was published in 2015 and another one in 2022 in the Journal of Clinical Sleep Medicine. Now, according to these, when this two step screening protocol, which included a questionnaire followed by pulse oximetry overnight, was studied against the gold standard PSG, they found that the predictive value was comparable. And they also did conclude that this feasibility was very high for an inpatient environment where a full PSG may not have been available. However, it's a single center study and was done only in obese patients. So, this study specifically addressed obese hospitalized patients, which is like a subgroup. However, um, it will be something that can be looked at into future, and so the ASM did recommend that this is one of the options that can be done as a screening tool. Now, coming to the first golden rule that the guideline statement mentions as a good practice statement. If your patient is a known case of obstructive sleep apnea and you know that he takes treatment, the good practice statement says that we must continue to use the existing treatment, which means that a diagnosed patient on active PAP therapy or appliance therapy or any other form of treatment should continue that treatment and not withhold it unless it is contraindicated. And when would it be contraindicated? Say the patient came with facial trauma or the patient has any kind of burn on the face and you cannot apply the mask, or there's a very high risk of aspiration, patient is semi conscious or unconscious. The clinical tip here is that whenever your patient is using the PAP therapy, it's preferable to continue to ask him to use his own mask and own device. And when you are writing down these notes of this inpatient patient, do not forget to record that we are giving this patient this device, this mask, and this pressure setting. Now, if suppose your patient comes in a position where he cannot use PAP therapy and you know that this patient has OSA and used to use a PAP device at home, you can use other strategies. Some mitigation strategies can be you can ask the patient to sleep laterally in a lateral sleep position, or the head of the bed can be elevated a little more, or patient can be given nasal decongestions if that is also a part of pathology in his OSA mechanism. So all of that then needs to be done. Now let's look at this management pathway. If a patient has been admitted for any other comorbidity which is commonly associated with obstructive sleep apnea, so we know that this patient is a cardiac patient or this patient could be suffering from OSA as a comorbidity, and you think that this patient has an increased risk on screening for moderate severe OSA, then after this patient goes home, he may need a sleep consultation. So, either that sleep consultation and diagnostic testing can be done inpatient, and the treatment can be started if there are no contraindications, or else once the patient goes back and then is followed up and he's managed, then it can be done. Now, the second part is where you know that this patient has OSA and he's on established treatment. Now, if this patient is on established treatment, he will continue it if not contraindicated. But if he is not on an established outpatient treatment, we are unsure of his sleep disorder, and but the screening risk is high, then he will be further worked up. Or, if possible, an inpatient sleep consult can be done during the hospitalization and he can be treated. The second recommendation that the guidelines have provided are regarding inpatient PAP therapy. Now, here what they have mentioned is that these patients who are medically hospitalized with newly diagnosed OSA, who are not on PAP, they should be given PAP rather than no PAP. So, here when you're considering this treatment, you have to look at patients where the outcomes will be meaningful. You have to look at patients who have a moderate to severe sleep apnea and who are suffering from comorbidities. And you have to also see whether this management of OSA will interfere with his medical care, and in that case, is the shared decision whether you would want to postpone it for later. But it's important for us to understand that we should preferably give PAP therapy versus no PAP therapy, even at this stage, if patient is amenable for treatment. The third recommendation is regarding a sleep consultation, and here it is recognized that there will be a very variable availability of expertise and resources for sleep medicine consultation, therefore. So, an oversight by this board, by the guideline, says that you would try to provide the consultation right away, and you may also get him into diagnosis and treatment pathway if possible, if it's available. And this feasibility has to be discussed, and this comes from an observational study where they had demonstrated that there is a chance of improvement of the number of follow-ups in patients in whom you would do a PSG at this stage, and the diagnosis will increase. So therefore, although this is a conditional recommendation and it stems from an observational study, however, they support that the evidence supports that this diagnosis here would lead to better clinical outcomes, so it is aligned with that recommendation. The fourth recommendation is the peri-discharge management of medically hospitalized individuals. And here we are looking at the question that these individuals with an established diagnosis or with an increased risk of OSA, when you are giving a discharge plan, you must ensure the timely diagnosis and effective management rather than not giving any plan. So, here the timeliness, we have to consider expediting this evaluation and management plan. We have to link it to the care. So you could order a post discharge test or evaluation, and if possible, you could do an inpatient sleep test. And so this is really important. And again, this stems from one RCT and almost six observational studies in which the pooled estimates showed that the clinically meaningful improvements were seen in mortality, in the incidence of OSA related comorbidities, in the readmission and PAP adherence. So, the overall certainty is very low for the evidence. However, a good peri discharge management plan will be feasible and will be optimal to follow. Now, regarding the very important question whether we should be doing this inpatient diagnostic approach using just the questionnaires or using limited sleep studies like a level 2, 3 unattended study or an oximetry or a full PSG or a split night study or a study with titration. Now, that essentially, according to this statement paper, will depend on the resources that you have, the cost that may incur, the patient that you're selecting, and to ensure that you will be able to conduct the whole study. So, in these studies, in the data that they have ascertained, they have used everything. They have used unattended type 2, type 3 studies. They have also used full PSGs. But since it may not be available in all institutions, the recommendations say that whatever best can be done for a patient in that clinical setting to optimize treatment can be tried with this thing in mind that some people may need a proper investigation evaluation after discharge. So, if a home sleep apnea test is more cost effective in such a setting with a lower resource utilization in a patient who's in hospital, it may be used as a screening. If HRPO is possible as a screening, it can be done. So, the guideline kind of opens the gates for trying to screen the patients and confirming the diagnosis at an interval at a time when it may be feasible. So, this is the summary of the recommended interventions in this guideline. And here, if you look at it, then the conditional recommendation exists for all of these rather than a strong recommendation. And here, the intervention of doing screening in patient for diagnosis, treatment using a management pathway is a conditional recommendation. Then, using PAP therapy and peri-discharge management also. And with that, we shall end this video, but I'll be back soon with another new video. Thanks for liking. Please do subscribe this channel.